Okay, well, why don't we go ahead and get started here? And we were talking about labral tears and instability, and we saw a bunch of different types of tears. And now let's go on to what postoperative changes look like. So this is just a diagram from an article in Radiographics where they just show the typical appearance of a labral repair. And it's very common to use 3 suture anchors, as we see here. You drill the holes in, you put the suture anchors in, then you tie uh, the sutures around the labrum and tie it back in, and you prepare the bone to a little bit of healing to try to get healing, or with a little bit of bleeding to try to get healing in this particular case. But I've seen anywhere from 1 to 7 anchors. So 3 seems to be a very common one. And these just they can look like a number of things. Most of the time, what are used here are not metallic anymore. So, but if they're metallic, you can get a lot of artifact with MR. If they're non-metallic, you can just typically see just bones, holes in the bone there. So here's a typical appearance. These are metallic artifacts, and we can see the 3 little suture anchors there. In this case, in the axopedi fat set, we can see the metal artifact from the suture anchors there. And here again are the suture anchor placements. With metal, you often obscure visualization of the labrum. But even if you don't have metal artifacts and you can see the labrum, the shape of the labrum is typically not normal after a repair. You lose the nice triangular appearance in the sharp edges. So that's pretty normal. So this would be a Bankart repair. Here we can see a number of suture anchor placements here. Here the typical non-metallic and a little bit different locations. This is a more superior and anterior glenoid, and we can see it here as well. And that's the area. And if we go in the area where we have the suture anchors, we can actually see that there's no fluid going deep to the labrum. But when we go off to the edge here, just inferior to the suture anchors, we can see a little tear in the labrum inferior to where the repair occurred in that location. Sahar, what do you think of this case?
We have axial view of the shoulder, and there is a suture anchor in the anterior glenoid where Bankart repair. And there's some increased signal in the labrum, but there is no fluid extending to that, so I assume it's expository contusions.
In here?
Yeah.
You say there's no fluid?
There's no. The intensity of the signal is different than the fluid contrast.
You can see it's heading in here. That's an abnormal morphology. And there you can see that there's something coming in here, and then it's a little bit darker in that location. But this was a tear in the area of the repair. And if you go farther down, we can see that this was a recurrent labral tear, and it occurs right where the anterior band of the inferior glenohumeral ligament has really kind of pulled off the labrum in that location, or the glenoid. So that was a labral tear. Shiv, what do you think of this case?
So we've got a coronal image, and it looks like there's been a repair. I see metallic artifact in the superior glenoid.
Okay, so we see so we see these anchors there. What's this thing down here?
I believe that's the inferior glenohumeral ligament. That's attaching.
Okay. Here are the axial images.
Okay, so we're inferior here, and it looks like, I believe it's the inferior glenohumeral ligament that's sort of medially.
Okay, okay.
That there. It could be labrum, or it could be the
VHL. So this turned out to be labrum. The labrum tore off here. This was a retear, and this is that periosteal attachment of the labrum. So this is kind of a Perthes, a postoperative Perthes lesion here. And if you follow this, we don't have all the image here. If you follow it, it won't go down into the inferior glenohumeral ligament. If you follow this, it'll just be flapping in the breeze, or it'll come back to the labrum. In this case, it was just flapping in the breeze. So I guess it could have been a tear of the anterior band of the inferior glenohumeral ligament, but this was really a re-tear of the labrum. Thomas, what do you think of this case?
So 24-year-old with recurrent dislocation after labral surgery, arthroscopic repair.
Okay, so the question the surgeon's asking is, should they do an arthroscopic repair or should they do a coracoid transfer procedure?
Okay, so having recurrent dislocation after labral surgery. So we're in a sagittal view and we see at least 2 suture anchors,
Okay.
anterior, superior, and superior. So if they're having recurrent and there's a flattening of the anterior glenoid.
Okay, good.
It'll be from prior osseous Bankart injury.
Okay, good.
And so now we have a coronal view. Yeah, there's sort of a defect of the inferior glenoid.
Yeah, something's been pulled off there and medially retracted here, and we don't really see a labrum here.
Right. So yeah, so they and then there's the anterior inferior glenoid also. There's a defect.
Yeah, so there's
so should be a
bone defect here.
Right. So this would be an osseous Bankart.
Yeah. So here's a situation now. That's basically the information that the surgeons need to know. Now we would also like. I don't think we've. Hopefully, it'll come up in the next few slides. If not, I'm going to have to make one tomorrow. Where you need to measure, you need to extrapolate where you think the anterior margin of the glenoid is going to be here. And you can do that both on the axial as well as on the sagittal images. You can do a fit with an oval into the glenoid. Determine where you think the anterior band is. Then you need to measure this distance and the total distance. And then if this distance is, classically it says more than 25%, 25% or more. Some people will say 20% or more. But if you have a significant amount of bone loss here, then that typically requires some sort of a bone surgery, not just a labral repair, because you don't have enough glenoid there for stability. And there, people will either do a coracoid transfer or they'll put in bone grafting in this location to try to redevelop the glenoid. And the most common one is really a coracoid transfer right this time. And we'll talk about that in a little bit. That basically moves the coracoid over so that it acts as a buttress so that the humeral head can't sublux anteriorly. It comes up to a bone block there. But we'll talk about that specifically in just a little bit, what that is.
That's the same on-track, off-track concept?
Yeah. So the on-track, off-track we'll come up with later. That's a little bit different. On-track, off-track has to do with the size of the Hill-Sachs lesion. To determine if you go through a normal range of motion, will the Hill-Sachs over here actually articulate with the glenoid, producing a rough surface and pain and injury to the articular cartilage. So that's on-track, off-track lesion, which we'll talk about it in a little bit. So generally, that measurement, what you have to do is we'll come to how to do that measurement later. The issue there is if you have too much of a bone defect, then simply a labral repair is not going to be a stable repair. So you have to do some sort of a bone thing, in which there are a lot of them, and there are a lot of new techniques which people are trying these days. That's one thing that has to be considered. The other is if the Hill-Sachs lesion is too large, then it might engage. And in that case, you have to do a soft tissue repair, typically called a Remplissage, where you sew the posterior capsule up on the humerus so that it inhibits the person from being able to move their arm in such a way that you get engagement. It keeps that from happening. So I think we'll talk about both of those in a minute.
So was the answer for that one?
The answer for this one is that there was enough bone loss where you'd have to do some sort of a bone procedure there, right? See, Thomas, you took the last one, right?
Correct.
Sam, why don't you take this one?
Okay, 18-year-old status was Bankart repaired 10 months ago. Re-injury, question of Retear. So, yeah, it looks like I think there was a bone procedure here as well as an anchor. That sharp hypointense line running through
Yeah,
the bone, not that's an anchor, I guess, but
yeah.
yeah, so then
This is,
there, right. And then the retear. So the labrum is also torn again, so
yeah. This is not a bone block right here. That's not where you place the bone block. We'll talk about that in a minute. Yeah, this is just a recurrent tear. You can see where the labrum is torn off right here. The patient had a redislocation and it sheared off the repair. And this is the labrum out there with the periosteal attachment, which is thickened.
That's
okay.
between the
And that's scarring and just soft tissue. This is just areas where the periosteum has elevated away from the bone.
Right.
Okay. Here are just other images showing that. This patient, this looks like a typical Perthes lesion that we saw before. It's just this is one in someone who had a prior repair. And then there we can see the acute Hill-Sachs lesion that goes along with it. In this case, the new tear extended superiorly to involve the superior labrum as well. Okay. What do you think of this one, Sahar?
32-year male with shoulder pain and limited range of motion. We have fracture of the glenoid. There is like a pulmonary edema of the glenoid, and we have a Bankart lesion. Also,
Okay, there's a Bankart lesion.
Yeah, and also we have a Hill-Sachs.
And a Hill-Sachs back here. That's 5/16/2017. This is what it looked like 2 years before.
Okay, we had that Hill-Sachs before, but the Bankart seems like it's getting. Actually, it looks new.
Yeah, so yeah, now if we look at some other image, here are the sagittal images.
Okay, so they did a repair.
And let's go back here. See, that's before. And then here,
In 2015, there was there's like fluid.
okay, so here's the Bankart. This is a very large Bankart. And if we go back here, this is really a very large Bankart lesion. It's very close to the margins of the glenoid. So this was one that was an engaging lesion. And then if we actually go to the sagittal images here, what we can see is this is what it looked like before surgery. This is what it looked like after surgery. And these are suture anchors here. What are these suture anchors for? This is in the humeral head, not in the glenoid. So what are these?
Yeah, they did like a soft tissue repair.
Okay, this is the Remplissage procedure. This is where they took this capsule that's over here, they put it onto the bone there, and then they tacked the capsule onto the bone here so that they wouldn't be able to engage the Hill-Sachs lesion. Okay. Shiv, what do you think of this case?
Okay, I see metal artifact in the glenoid. Looks like the inferior glenoid metal artifact. Can't really see the inferior labrum all that well. Inferior.
So this patient's had surgery. Do you know what kind of surgery?
Okay. Is this a coracoid transfer?
Yeah, this is called a Bristow procedure, which is a coracoid transfer. John, do you want to tell us what a Bristow procedure is?
Yeah, Bristow was an orthopedic surgeon, professor type in South Africa. And his student came up with this procedure and named the procedure after his professor. So it's not the guy that invented it. That's not his name. And the student apparently really liked his professor. But anyway, what the procedure is you split subscapularis longitudinally down to the capsule and to the neck of the glenoid. and also you remove the coracoid process, a portion of it, about a centimeter or so, and drill a hole in the tip of the coracoid process, and with the conjoint tendon, you place that in front of the glenoid. Of course, you have to drill a hole in the glenoid adjacent to the articular surface. There are many different ways to do it. The way it was described initially, it was no screws were used, and all they did was remove the tip of the coracoid process and then stuck it through a hole in subscapularis in front of the neck of the humerus that produced scar tissue and apparently was had some success. But the modern way to do it is split subscap, and then the way I like to do it, and it's my own way of doing it, is split it longitudinally and transversely on the inferior surface, and then do the other things, drill a hole in the front of the neck of the glenoid, and drill a hole and attach the coracoid process tip right in front of the glenoid, and then suture the inferior portion of the subscap that you transversely cut, and kind of overlap a little bit so that you get a little tightening effect, so that and so you have a fixation, and you also have a sling, so that the head will go into the sling, and you also have a bone block. It's kind of hard to explain. It's a lot easier to show in a picture, but I'm doing the best I can. Anyway, it's a bony procedure. It's extremely effective. I had one individual, he was a dope addict that liked water skiing and surfing, and I reduced his shoulder. It was a neighbor, and I reduced his shoulder in my kitchen table one time after he dislocated it. Anyway, I had to redo his shoulder because he went surfing and had a severe injury again. So none of these procedures are effective if you cause a trauma that caused the initial injury. So, but the Bristow procedure, I would say, has about a maybe 5% recurrence rate. It's not easy to do. It takes a little work. But overall, I like the Bristow the best.
Great, thanks.
So anyway, one thing about the shoulder dislocations, the younger you are, the worse things are for you in terms of the future. If you dislocate your shoulder under the age of 20, you're going to have a very a good possibility that you're going to have a recurrence more than once, probably, even after a good operation. As you get older, things are much better. that usually means is that you have a predisposition for a dislocation if it happens to you at a younger age. And I've had patients that bilateral shoulders were dislocated, and I'm sure that was congenital predisposition.
Good.
Anyway, it's a great procedure, and you cannot do that arthroscopically.
Great, John. That's right. Thank you. So,
Dr. Cruz?
yes.
Dr. Cruz, I have to step out. They need the room for a DEXA scan.
Okay.
So I'm going to try to log in with my phone, but if not, it'll be like 10 minutes. So.
Great. Thank you.
Okay.
Yeah. So the other area to look at so one area here that we're looking at is really the posterior greater aspect of the greater tuberosity. And there are injuries in this location. There are really three things to consider. One is the Hill-Sachs fracture. The other is an erosion due to chronic traction injury, the infraspinatus. You've both seen a lot of these already this year. And this is also the area where we get abnormalities from posterior impingement if we're dealing with high-level overhead athletes. So so when you see a lesion in this location, that's really the differential you have to think about. So this is someone on 3/20/2003 who had an old Hill-Sachs lesion here. We can see kind of sharp margins. See a little bit of erosive change here on the PD fat sat. Oops. I'm sorry. At this particular time, it was acute because we can see the edema here. When you follow this over time, so about 9 months later, when they came back, we can see it's nice. It's much smoother here, and that edema has gone away. So the way we determine whether it's an acute injury or not is really the degree of bone edema that's involved. Let me see, who did the last one? Okay, Sam, what do you think of this one?
Okay, there's a little bit of an indentation, I think, of the posterior humeral head. There's this, looks like some, change in signal, some indentation there. Yeah.
So
this
what's going on, do you think, here?
Could be traction. It could be a Hill-Sachs. It could be overhead throw, although I think it would be lower down, wouldn't it, if it was from throwing?
No, the throws are also high up in the same location. So we see irregularity. Then the next thing we need to do to determine what it's from is look to see if there's an anterior labral tear, right?
So it's not, so it's not from dislocation.
Okay, so this is kind of, there we don't see abnormality, but look what happens when we go down below.
Yeah.
So what's happening with the labrum here?
Well, this is anterior inferior labrum, correct?
Yeah. So the anterior inferior labrum is really missing.
Yeah. He could have dislocated and torn off the labrum there.
And then if we go inferiorly there, we can see a lot of irregularity of the inferior labrum.
Yes, he dislocated it there.
Yeah. And so now, the one thing to remember is that the location of the Hill-Sachs lesion can vary depending upon exactly the direction in which the dislocation occurred. So most dislocations are kind of anterior to anterior inferiorly, remembering that the glenoid is rotated. So if you go back to the sagittal images, if you remember, you can debate about what's anterior. The anterior glenoid is actually, since the glenoid is rotated forward, the anterior aspect of the glenoid is actually anteriorly inferiorly with respect to the rest of the body. So most dislocations are anterior dislocations. And therefore, if you just look at the axial images, they tend to involve the anterior and anterior inferior labrum, which, because of the rotation of the glenoid, is really anterior. But you can have straight inferior dislocations, in which case you can have an injury to the inferior labrum, and then the Hill-Sachs lesion can be on the top of the humerus. And then you can have posterior dislocations, in which case basically the Hill-Sachs lesion is anterior, involving lesser tuberosity, and the labral lesion is posterior. So just remember The bone lesion is kind of like 180 degrees from the labral lesion, but they can vary depending on the exact direction of the dislocation. Okay. So, Sahar, what do you think of this case?
The Hill-Sachs, which there's also the label is that you said little blonde
Yeah, well, we're very high, so that's not the right part of the labrum to look at. So we can certainly see that we have a lot of irregularities here. This doesn't have the typical V-shaped configuration that we're used to with the Hill-Sachs. This is what it looks like on the sagittal, kind of indistinct, with more kind of erosive changes rather than what looks like an impaction type injury.
fraction.
And this was all due to chronic traction injuries from the infraspinatus, which, as you guys know, if you do anyone over the age of 30, they're going to have some traction injuries there. That would be almost everybody has some degree there. Okay. Shiv, what do you think of this case?
So it looks like we have a cystic focus on the superior, posterior aspect of the humeral head. And I'd be worried about traction injury here.
Yeah. So this is another traction injury where you really develop really more of a mature cyst type appearance in the subchondral bone. Right. Okay. So I think you guys have seen this before. I think we talked about this. This was a baseball player, and this is an ABRA view with an arthrogram, and we can see an impaction injury here that looks a lot like maybe a Hill-Sachs. It's in kind of that same location, though it's a slightly different orientation. If you actually look at the orientation of the V, we can see that there's fraying of the rotator cuff in this location. And usually you don't have this, but in this case, there's a loose body there. And this is a baseball pitcher, and this was due to chronic repetitive impaction of the posterior superior aspect of the glenoid, not against the anterior inferior, of the superior posterior aspect of the humeral head, not against the anterior inferior glenoid, but against the posterior superior glenoid and the cocking position, which was the internal impingement.
What's interesting is how they can tolerate the pain to get the ABRA view.
Right.
And just imagine when they're throwing a ball, how it feels.
Yeah.
So, it's really not natural to throw a ball that way.
Mm-hmm. Okay, so that's a little bit about anterior labral tears. Now let's talk about posterior labral tears. They're typically caused by posterior dislocations, and there are a lot of reasons for posterior dislocations or posterior subluxations. Classically, they're posterior dislocations, and the classical cause was seizures due to muscle contraction of seizures. In our world, much more common cause of posterior labral tears or chronic repetitive subluxation, primarily from weightlifting. People who don't do bench pressing properly, and when they come down bench pressing, the humeral head rotates posteriorly and keeps impacting the posterior labrum with a lot of force. So you really, when you do bench presses, you should not allow the elbows to go more posterior than the glenoid. But a lot of people like to bounce the humeral head off the posterior glenoid because that gives them a little bit more force when they push on the barbells, and they can bench press slightly more weight that way. So that's the most common cause of posterior tears that we see. Then there's a Popsal lesion, posterior labral sleeve avulsion, and when this becomes calcified, it's a Bennett lesion. And this is just basically tear the posterior labrum where the periosteal attachment becomes thickened, and in a Bennett lesion, it becomes calcified. And then there's a Kim lesion, which is not a tear to the surface. It's an injury to the substance of the posterior inferior labrum, where the labrum then no longer has mechanical support. It just is squishy, and therefore doesn't provide good stability posteriorly, inferiorly, and it's usually due to repetitive trauma from sports injuries. If you have a definite Kim's lesion, then this is one that typically is surgically repaired. You basically tear it and then put it back in with a labral repair posteriorly, inferiorly. Okay, let's see. Shiv, are you next?
Fell whilst hitting a Picasso from dropping in Malaysia. So it looks like it could be a posterior dislocation here. I sort of see a light bulb sign.
Okay, so yeah, if you look at this, what you can see is there's a groove here. Now, if it's an intertuberous groove, it shouldn't be in the joint space, so that's suspicious. Also, in this AP view, the humeral head and the glenoid are really overlapping one another. And then if you try to do other views, you can't really separate the humeral head from the glenoid on the plane radiographs. And here's the MR.
So yeah, it looks like a posterior dislocation or subluxation.
Okay, so here's a posterior dislocation and kind of a reverse Hill-Sachs. Yeah. Okay. Here's a subtle case. Sam, what do you think of this case?
Well, humeral head is definitely posteriorly dislocated. The glenoid looks like congenitally deformed. There's some retroversion, probably like 10 degrees, 15 degrees extroversion. And it's just flat looking, just probably congenital dysplasia or something.
And a 9-year-old male, you're really going to be concerned about congenital lesions if they're unstable. Here's what the MR looked like. What do you think of that?
Wow. So just more of the same. The glenoid doesn't look as abnormal to me on this one as on the last picture. But
yeah, we can see the soft tissue. We see that most of the labrum is still intact, that posterior labrum, but here we can see the dislocation here. John, with these posterior dislocations, are there any other injuries that we should be looking for on MR scan?
Well, they all vary, and they start dislocating at an early age with the grand mal seizures, and before they're medically corrected, you get all kinds of nicks, and I can't really give you a whole list of the different ways that they dislocate, but it's a real problem. They're harder to fix than the anterior ones too.
Yeah, great. Thomas, what do you think of this case?
Can you hear me?
Yes, we can.
Okay. Yeah. So there's a posterior dislocation. Looks like a reverse Hill-Sachs. There's edema in the humeral head.
Okay.
And yeah, some edema in the teres minor.
Okay, so this is on 6/28/06.
Okay.
This is on 7/1/06.
Right. So it's been reduced at the glenohumeral joint. There's a persistent reverse Hill-Sachs deformity of the medial humeral head. The subscap's intact, and the posterior labrum. It's maybe a little bit of irregularity there.
Yeah, maybe, but we certainly don't see a displaced tear back here. It just shows that you don't always get a displaced tear when you have a dislocation. This is clearly dislocated, and this is just an acute reverse Hill-Sachs. Good. Sahar, what do you think of this one?
Okay, 22-year-old male athlete, 16 days after injury. So we have a posterior labral tear, and we have kind of like acute, subacute, reverse Hill-Sachs. Oop. Okay, that's the capsule.
Yeah, this is the middle glenohumeral
glenohumeral.
ligament, which with the posterior dislocation was actually torn, and this patient as well. So you can look for the capsular injuries and other stabilizing injuries when you have these reverse Hill-Sachs. Okay, here's a subtle case for Shiv.
All right, so it looks like the humeral head is badly deformed. There's a big V-shaped deformity. Massive Hill-Sachs. Big fracture actually going all the way through the.
Yeah, more. At least 3 parts.
Yeah.
So that was really a fracture dislocation. And if you notice, this is someone who has severe fatty atrophy of the muscles.
And better get a look at the neck.
Yeah. Now, and why do you say that, John?
Well, it looks to me like there's a lot of neurologic loss.
Yeah. Good. Okay. All right. Let's see. Sam, what do you think of this one?
I think the edema this time is in the anterior humeral head, and there's, I guess it's a Perthes, a posterior labral tear with stripping of the periosteum displaced.
Yeah, except I think it's completely torn. I don't think it's attached anymore.
It's not attached at all.
Yeah.
So
It's not technically a popsal lesion or posterior Perthes lesion because the periosteal attachment is torn. But it doesn't really matter because whether it's the periosteum is torn or not does not change management. So, and there's probably some injury here to the articular cartilage, like we saw in the anterior aspect as well. So that was a posterior dislocation. Let's see. Thomas, what do you think of this case?
So we have axial coronal view. Looks like there's some increased signal in the anterior muscle and deltoid.
The delta.
And
So
yeah, sort of diffusely increased signal.
So what do you think?
So yeah, it's like an axillary nerve.
Yeah. So one of the problems, you can see this patient's had prior surgery, but one of the issues you always have to be concerned about with dislocations, especially posterior ones, is injury to the nerves and get denervation syndrome. So you have to carefully look at the muscles surrounding the joint if you're concerned about a dislocation. And that's pretty much anywhere. It can also occur in the knee. Okay. And then here's just a posterior labral tear we can see back there. Yes.
The problem with grand mal seizures is that they recur, not infrequently, and it's hard to find the right medication to prevent the recurrence. And all it takes is one seizure, and all your surgery is kaput.
Right.
So, it's a very difficult problem to deal with.
Yeah. Is it Thomas next? Thomas, what do you think of this case?
So it looks like the posterior labrum is torn.
Yeah, we're posteriorly superiorly here. But this is probably the posterior capsule in this particular case. So the labrum may be torn. I don't really remember, but the primary thing here was that this patient had a capsular tear, and they actually went in and repaired the capsular tear here.
Okay.
So
90-year-old male, recurrent dislocation, multidirectional instability, and no trauma. So the arrow is pointing to the posterior labrum. There is some increased signal in the posterior labrum.
Okay, and then Dr. Su thought that the periosteum was attached there, so he thought this was a popsule type lesion. And it just shows some of the schematics of this. Again, I'm pointing this out simply because you'll hear these terms. My understanding is both anteriorly and posteriorly, if the periosteum is still attached, it makes no difference. The surgery is the same. So it doesn't really matter, but some people really like using these acronyms, so you need to kind of know what they are. So anteriorly, here's a Bankart. Here's the Alpsal. I think Dr. Su probably took this from Stoller's book. Alpsal, it's displaced and gets scarred down. A Perthes, it's torn, but the periosteal attachment is the case. Reverse Bankart, and then the popsal lesion or the posterior Perthes lesion. There, okay. See a shift?
So it looks like there's a posterior labral tear and the periosteum is thickened, possibly calcified. So it could be a Bennett sort of.
Okay, so that's a posterior sleeve avulsion. Sam, what do you think of this case?
It looks like a kind of a crescentic calcification along the rim of the, that there, the glenoid there. So I guess it would also be a calcified periosteal like stripping or something.
So in this projection, it's a little difficult to see this, but anteriorly is here. This is posteriorly, so this is along the posterior margin of the glenoid, and so this is what would be called a Bennett lesion on X-rays. Here's what the MR scan looks like. What do you think, Sam?
Actually, the anterior labrum is not normal here either. But posteriorly, also is abnormal labrum with the periosteal thickening.
Right. So this was the area that was calcified. It's hard to actually see the calcification on MR. Again, the calcification is not really that important. This is a chronic posterior labral tear with thickening and scarring of the periosteal attachment or a chronic popsal lesion. In this particular case, this is a classic Bennett lesion as defined by the X-ray findings. But that's what these are. Okay. Thomas, what do you think in this case?
So if axial view, posterior labral calcification on X-ray.
Yeah.
So the tear of the posterior labrum with a lifting of the periosteum, and I guess.
Yeah. So this is just another Bennett lesion. Again, it's a chronic posterior labral tear. We can't really see the calcifications here. Again, they're not important, but this is just a chronic posterior labral tear. Okay, good. Okay, Sahar.
Right shoulder pain for 3 years, baseball player. So I see some thickening of the posterior capsule. Yeah.
Here.
Right. And on the plain film, there's some calcification along the posterior glenoid, so like a Bennett lesion.
And here's the CT.
So same thing, there's like ossification in the region of like posterior capsule.
Right in through here.
Yeah.
So this is a Bennett lesion, the MR and the CT scan of the Bennett lesion. Okay. Shiv, what do you think of this case?
18-year-old male with instability. So it looks like there's thickening of the posterior labrum. There's a little focus of high signal just between the cartilage and the.
Yeah, so there's obviously a tear here.
Yep.
It's displaced. There's probably some periosteum still there. Okay, and then here's the appearance on the sagittal images. And this just shows you how the glenoid is rotated about 20 or 30 degrees anteriorly. So this would be anterior for the body, anterior for the glenoid is down here. So maybe 40 degrees of rotation. So this is what it looks like on the MR examination, and this is what it looks like on the CT.
So there's a
Here's that sagittal CT, and if we go back here, this is all calcified through there, and we have calcification here, and here we can see the calcification. So this is another Bennett type lesion, and what they look at like both on CT and MR. Sam, what do you think of this case?
Okay. There's a little, I guess, cyst in the humeral head, which I don't think is related to trauma. I would think traction or something. Humeral head morphology looks okay. The glenoid morphology looks okay. Labrum doesn't look too bad. There is a little, yeah, I was going to say, there's a little bit of decreased signal focus in the, just like below the inferior glenoid there.
Notice that the inferior rim here, instead of coming up as a sharp point,
Yeah.
it's flattened back here. And
Yeah.
this is the edge. This is the edge of the glenoid. Notice how it kind of flattens back here, and the labrum, instead of coming out to a nice point here, is flattened back in this area. This is posteriorly and inferiorly. This is on 5/30/2008. Here's what the axial images look like. And here
Okay, so yeah, posteriorly it comes back, it like angles back a little.
and we can see a lot of periosteal thickening here. But it looks like it's been kind of an impaction here. Looks like maybe the labrum might be a little bit softened here. And this surgically was a Kim lesion. So the surface of the labrum was intact, but when you press on it, it was really soft and wasn't stable and did not give good stability here. So this is a Kim lesion. And you just have to treat it surgically. Here's another Kim lesion. We can see the irregularity here, that the posterior inferior glenoid and labrum, and you can see again the flattening of the underlying bone here, which is part of the instability of these lesions. This is 9/14/11. Vision had persistent instability. Okay.
Why doesn't it fill, Dr. Cruz? Why isn't it filled with fluid? There seems like there ought to be a gap between the bone and the labrum if you can press it down.
You have kind of impaction, and they stay together. It's not a tear of the surface. It's an impaction injury, and the substance of the labrums gets injured, so it becomes softened. And often you'll also have a little impaction of the edge of the bone, but you don't get a separation between the two. And therefore, it's hard to see arthroscopically because the surfaces are all intact. It's just that when you probe it, it's not stable. It's too soft.
John, could that be a vertical dislocation?
Vertical. Certainly, I think that a mechanism that can cause this is recurrent subluxation or dislocations with injury to the posterior inferior labrum and glenoid. I think any mechanism that could do that, right?
It's pretty hard to fix that one.
Yeah. Okay, let's see. Okay, say, Thomas, what do you think of this case?
So I have multiple axial views, PD fat set and PD, and the posterior glenoid. There's sort of some irregularity, remodeling, and the
Hasn't changed there.
so we have a coronal and sagittal view.
Yeah,
So the inferior.
Yeah, that inferior, posterior glenoid and labrum. And this is just another tear. This is the Kim lesion.
Sometimes you can see a nice signal there too. Is that? on
Yeah, sometimes. Usually not. Here's a case where you can kind of see the increased signal intensity in that area as well. But you can see it just looks blunted as if it's not stable. And when you press into it with at arthroscopy, instead of having a nice firm labrum, it just gives way so that it's it does not allow for stability back there. And so the typical, you go in, you basically separate it, and then you put in suture anchors and you tie it down, hoping that that repair will give more stability. And this is just the POPS lesion we've been talking about. Okay. Let's see. Thomas, did you do the last one?
Correct.
There you go.
13-year-old male with bilateral shoulder pain 1 week after bungee jumping. So it looks that there is a tear of the supraspinatus.
The supraspinatus up here.
Yeah. Or RV out of plane.
It may be a very tendinotic with a lot of increased signal intensity here, but I think it's intact.
And there's some there's like edema along the biceps and deep to the deltoid. And there's tear of the inferior glenohumeral ligament.
Yeah, well, okay, so we can see that there is increased fluid here in the inferior capsule. The inferior capsule certainly looks stretched, and it looks like it's torn off the humeral attachment. And then here this is a typical appearance. The inferior capsule comes down here, and then it's torn and displayed.
That's the glenohumeral ligament.
Yeah. And so what's this called?
Hagel.
A Hagel lesion, right? Humeral avulsion of the glenohumeral ligament here. In this particular case, the patient actually had a dislocation and a fracture from the bungee jumping, which caused it, and he had this in both shoulders. This is and these are the common injuries that occur.
You know the nationality of Hillary Ullman's?
Nationality of what? Oh, humans? Hillary humans? I don't know. I'll ask her the next time I see her. Do you know it?
Latvian.
Oh, is it really? Okay.
Well, I can tell by the name.
Good. Okay.
Just curiosity.
24-year-old MLB pitcher, new clicking history of labral repair. So I do see.
Good-looking gals.
I see a metallic artifact in the glenoid. It looks like the posterior labrum and part of the capsule is probably a little thick too.
Okay.
And there's some high signal there as
There's
well.
probably a little tear right where the repair occurred. And there you can.
That looks like a Hill-Sachs.
Yeah. So I think this patient probably had multi-directional instability, and this was a retear of the posterior labrum. Okay. Sam, what do you think of this case?
So aside from the obvious posterior labral tear, I think that the glenoid is also flattened posteriorly, and there's also some retroversion.
Yes, a lot of retroversion, a lot of underdevelopment of the posterior glenoid, and this is a large labrum back here which is torn. So this is one of the more common forms of glenoid dysplasia, and most of these people end up with very unstable shoulders. And you can see why, because usually you'll have a large posterior labrum, but there's so much force against it that eventually that labrum tears in these individuals. Thomas, what do you think of this case?
26-year-old with abnormal X-rays, multidirectional instability. So yeah, that posterior glenoid, I'm not seeing a normal posterior glenoid rim, and sort of like soft tissue thickening posteriorly.
There's retroversion, a large labrum. So this is another dysplasia similar to the last one. not quite as much retroversion, but it's still abnormal, and there's underdevelopment of the posterior glenoid and then the tear here. This patient you can see has kind of an odd location for a posterior Hill-Sachs injury. Because of the dysplasia, his dislocation was more anterior and superior, which caused a more inferior impact injury posteriorly. This patient also has an anterior impact injury here from the posterior dislocations. Okay, so why don't we stop
The head is, John, is that the head is deformed, isn't it?
Well, the glenoid and the head are both deformed, right?
Yeah.
Yeah.
It's a congenital.
Yeah.
I would think.
Yep, I think so. Okay, so why don't we stop here, and tomorrow we'll start talking about, we'll go to labral tears and discuss those. Any questions? Thanks, everyone.
Why don't you ask Melinda if she wants to go to have breakfast on Saturday?
John, Saturday I have to go to USC. I'm lecturing at a